There is often an assumption that implementing evidence using the approach called facilitation is always beneficial, and that if you start implementing using facilitators, then immediately evidence becomes implemented. But the more research we conduct into the process of implementation and the more knowledge we gain as a result, the more we understand that actually there are certain unintended consequences and hidden tensions that are involved in facilitation, and these mostly affect junior facilitators, novice facilitators, those people who have relatively limited experience in implementing evidence in practice, and also those people who have relatively low positions in the clinical hierarchy. So what are the main components of the dark side, so to speak? The first thing I would say is that facilitators are very often occupying intermediary positions. That means that they belong to several groups, several camps. On the one hand, they're usually clinicians, so they have their clinical background and their clinical affiliation with the nursing community, for example, or with allied health professions. On the other hand, by becoming implementers, they immediately assume some kind of managerial role, which makes them hybrids. But as a result, they have to operate in between several camps. They have to still remain clinicians, they have to maintain their credibility as clinicians. At the same time, they have to be something different, and they have to work with people who do not necessarily have clinical knowledge or skills. Being in the middle, being in between, has its advantages, but very often it causes disadvantages, such as not knowing where to go for guidance, not knowing where you actually belong to, not knowing where your identity lies. So there are lots of psychological dark elements in that. And I think this is one of the main issues involved in being a novice facilitator. The second important thing here, the second aspect of the dark side, is that very often a facilitator has strengths in a certain clinical or managerial domain where they know only certain elements of the knowledge which is required to be a successful facilitator. To be a successful facilitator, you need to have clinical knowledge, you need to know something about research evidence, you need to know how management practice works. Most often, facilitators on their own do not possess all those skills. So being a facilitator is difficult because the number of things you have to know is too much. That's the second bit. The third bit is quite interesting, I would say, because facilitation usually involves enabling other people to learn how to work with evidence and research and change practice. So enabling is one of the key functions of facilitation. What we observed in our research is that when you become a facilitator, it is sometimes easier for you, because you have expertise in a certain area, to stop enabling other people to do things and instead start doing things yourself, where you stop being a facilitator, in effect, and become a doer and implementer. Of course, the work gets done, but it's not through enabling other people in health service to do that. So what's the learning? What's the likelihood that the initiative will continue after you leave? All these things have to be considered by novice facilitators.